Today in the business meeting and in the Acute Leukemia Working Party, we will discuss about the role of MRD during transplant. First, the role of MRD in the post-remission setting, and if this is an indication for transplant. We have now very good ALN guidelines how to handle this, but there are still open questions. For example, if some MRD negative patients with intermediate risk disease, if still they have to go to transplant or not. Maybe we can omit transplant. Also, we know now a lot of how to handle MRD at transplant. We know it's prognostic. There are still open questions. We don't know if we have to treat it before, but we know that this has an actionable value. We have to do something after transplant. For example, targeted therapy like FLT3 inhibitors. If we can do pharmacological intervention like ASA maintenance afterward, it's not clear. And if we should give DLI, it's also not clear. And so we have open questions on that. The most chaos and what we don't know, the most enigmatic, let's say, is how we handle MRD after transplant. What we don't know how to handle is how to measure and how to treat MRD after transplant, because after transplant, the transplant per se is a dynamic drug. We have a GVL effect. It might be that it needs some time to clear the MRD. So first, we don't know the techniques, how to measure it. There are many confounders, like in chimerism, like the DTA mutations. We don't know how to handle if there are host mutations or donor-derived mutations. And also, we don't know when to measure. And if we found MRD positivity, how to treat it. So this is something that we have to work all together. There is also the Measure consortium that is trying to answer these questions, and I'm sure that next year in EBMT we'll have some answers in these questions.